Yeah. Wasn't on the front.
Thank God.
All right, everybody. It's good to see everybody. It's a little after 4, so I think in the interest of time, we'll go ahead and get started. I know a few more people are going to probably trickle in. So welcome to this year's W. Kendall McNabney Endowed Lectureship. It gives me great honor to have our speaker with us here today. So, I like to share this picture just to kind of show what our campus looks like today, although actually this parking lot here in the foreground is now a hole in the ground as it's being developed into the latest School of Medicine building. So we'll have to update this, but obviously we've come a long way with what the campus looks like, and here's our wonderful university health building and current trauma bays, but it didn't always look like that. So here's a picture from Old General, which was located just not too far from here. So the Star did a piece on General back in '74. So may not be the classiest act in town, but its emergency room is a tough act to follow. So I would like to think that the ED still is a tough act to follow. So things look a little different nowadays than they did then. So it has few conveniences, but its emergency room boasts at least 2 doctors on duty at a time, and usually there are more. So that's true probably still today. So yeah, here's Dr. McNabney in the old trauma bay. So I appreciate the old defibrillator here. You remember these. So we've come quite a ways. So here's the biocom for answering EMS calls. So that thing is a beast. So Dr. McNabney again teaching us all. So he was the chair of emergency medicine here from 1972 to '86. He founded our residency program in '73. He was president of the University Association of EMS, which was the predecessor to currently what is SAEM from '80 to '81. And then he was on the ABEM Board of Directors from '82 to '86. So he really was instrumental in kind of the founding of our specialty. So I like to say that, Dr. McNabney embodies this quote, and that the mediocre teacher tells, the good teacher explains, the superior teacher demonstrates, and the great teacher inspires. And so I think Dr. McNabney truly did inspire all of us. And so this is just a collage of kind of all of our residents' class pictures. So he left obviously quite a mark on a lot of residents here. And for those that didn't directly know him, obviously his legacy still continues to this day. I always joke, I don't know how these residents got away with having, whatever mountain this is in the background. So yeah, yeah. So quite a few classes. So obviously here's the lighter side of Dr. McNabney enjoying a nice cold beverage. So and then here he is with his wife Elaine. So that takes us to introducing our guest speaker, Dr. Yvette Calderon. So Dr. Calderon earned her bachelor's degree from Brown University in 1983, then her MD from Albert Einstein College of Medicine in 1990. Completed her residency at Jacobi Medical Center in the Bronx, and then subsequently got her master's degree in clinical research from Albert Einstein in 2005. She started off her career as an assistant, then associate, then full professor at Albert Einstein, and then moved to Mount Sinai, where she was professor of medicine, and then later tenured professor of emergency medicine and medical education. And then this year just moved to Philadelphia and is professor of emergency medicine at Sydney Medical College. She's held a lot of different roles in her career, including being director-in-chief of emergency medicine at North Central Bronx Hospital, later then chair at Mount Sinai. She's been the system vice chair of diversity and inclusion for the EM service line there, as well as dean and vice president for equity and clinical care at Mount Sinai. And then currently is the chair of emergency medicine and Jefferson Health System leader for emergency medicine. So I think she was telling me today she's got 28 emergency departments under her, and how many different residency programs? Six different residency programs. So when I think my life is busy, I will refer back to that and know that I'm doing okay. So I pulled just a few things out of her immense list of things on her CV. So she is currently an ABEM director and serves on the executive committee of ABEM. She's the chair of the research committee. She's also a member of the National Academy of Medicine. And then I found it rather inspiring that she co-founded the Mentoring in Medicine nonprofit that works to mentor high school, college, and medical students. So she's done a lot of different things in her career. Research has been a big part of her career. She's received numerous grants from NICHD, the CDC, and the New York Departments of Health. A lot of her research is focused on health equality and disparities, hepatitis, HIV, counseling and testing and linkage to care, and then substance use disorder screening and treatment. This has resulted in more than 100 plus publications, abstracts, book chapters, 40 international and national presentations. And then lastly, she's been recognized with numerous awards, so including the New York Cranes Champion of Change Award, Jacobi Medallion Award, the Albert Einstein College of Medicine Lifetime Achievement Award, the ABEM Barbara Ross Lee Diversity, Equity, Inclusion Award, and then the last year, the SAM Cheryl Heron Legacy Award. So with that, I want to welcome Dr. Calderon and thank her for being here. So please join me in welcoming her.
Thank you. Thank you. Put this on. You guys can hear me okay? So thank you so much for inviting me here to give this presentation. I like to think of this as not so much a presentation, but a conversation that we're going to start. And there hopefully will be many more conversations among all of you as you go forward. Advancing health equity has been really the center of my career from the very beginning of picking Jacobi Medical Center, a incredibly vulnerable patient population, definitely a safety net hospital. It was my home for over 30 years before I went to Sinai and so forth. So honestly, it's not a surprise that this would be something that I am very, very passionate about. So thank you for having me, and we'll start the discussion. Let's see if I can utilize this instead. So I am someone really can't really know where you're going until you know where you've been. And so the history of what I'll be discussing a little bit or sharing with you is important. Now, my history, very briefly, is my parents were from Puerto Rico. And so they immigrated to New York a very, very long time ago. And growing up, I think I have a unique perspective because I can give you the perspective of growing up in the projects and actually facing the different disparities in healthcare from a patient perspective. And then, of course, give you the other side of it, which is really being a provider in emergency medicine and trying to provide the care, really good care, high quality care for all. So I really love this mantra that Brian Sink shares with us in his book. We care for anyone, anything, at any time. And really, it's been the mantra of emergency medicine from the beginning. But this particular quote, I think, is really important. Emergency medicine rose out of progressive social demand for services that were tied to the moral and ethical aspects of providing care for the poor and the uninsured people. Threads of egalitarianism, social justice, and compassion for the poor and underserved were woven into the brief history of the full-time emergency practice and the development of emergency medicine residency programs. And there's nothing more true than that. We really kind of rose out of a very young, specialty for sure, but we still rose out of the social justice principles that the people who were icons really showed, and they were exemplary in that they actually inspired. So I think that that's something that we have to, as we talk about advancing health equity, remember kind of where we came from. So what I'll do is really give you kind of a little bit of a historical perspective. I am not a historian. I just picked several different points in history that I think gives us a context by which we can start discussing health equity, especially with the emergency medicine lens. Talk a little bit about the social determinants, racism and its place within health outcomes, and then how do we achieve health equity within emergency medicine? What are some of the low-hanging fruits that you can be thinking about with respect to this? So first, I'd like to start with, when we talk about race, it's a social construct, and that when we have a conversation about genetic ancestry, it's not the same as race, right? We know that genetic differences are not fixed along racial lines, and that really what race is a classification system, right? Based on how you look, what you look like, the color of your skin, what your hair is, the color of your eyes, your facial features. And so if we can stand back and understand that that's really the most it gives us, especially when we're talking about science and talking about disease entities, I think it's important for us to just realize that. So unfortunately, the history of academic medicine really, unfortunately, is really based on a lot of unfortunate things that occurred during the history of medicine. And it's really based on the fact that when it started, we were teaching, or the medical schools at that time were teaching racial inferiority. There was a gentleman by the name of Samuel Cartwright. He was a prominent physician of his time. He was also known as the inventor of diseases. And so, in fact, this is pre-1900s, one of the diseases that he actually invented was this drapetomania, which is a mental illness that he claimed caused enslaved Africans to run away from their confinement. He argued that it could be prevented by keeping Black people in submission, and it could be cured by whipping them. And if that's not racial inferiority and being, taught in the medical schools, I don't know what is. So in the 1700s, we start building different hospital systems, what I like to think of as a two-tiered system, your safety net hospitals, and then those that were private. By the 1800s, you had Black hospitals, and you had your Black medical schools. But within that time period, we can't forget about the Jim Crow laws and the fact that these laws legalized segregation and legalized a lot of the punishments that went with that. So then we get to 1910, and the big, I think, part of history here is the Flexner Report. The Carnegie Foundation actually commissioned this report to be done, and Abraham Flexner was the person who did it. He was actually a teacher. I think he was like a high school teacher. So he went out and he really had to look at all the Canadian medical schools and all the medical schools within the United States. And during that time, those schools, I should step back and say that the Carnegie Foundation really believed that the medical school system during that time had a lot of issues with it. And so they wanted all the schools to kind of follow suit with the Johns Hopkins model, which in essence was what ended up happening. So once the report came out, there were 50% of the medical schools were closed based on this report, which meant those were the schools that had mostly women, had a lot of women in their classrooms, and also people of color, African American, that were graduates from those schools, really comprised a larger number. By closing those schools, you were able to control the number of seats that at any given point someone of color could be on, or even a female could actually be a part of the medical school. So it's interesting how that one report really framed medical education in the United States. In the 1930s, you had compulsory sterilization laws in 30 states. So you had women of color, whether they were Black, Native American, Caribbean, Latino, they were having forced sterilization. It was a way of contributing to the genocide of the time, right? It was really quite awful, and they didn't know that they were going into one surgery and coming out, being sterilized, much like the Tuskegee, right? That, we all know, was really a natural experiment of allowing human beings to have a disease while telling them they didn't have the disease, and then just observe them. If that's not unethical, I don't know what is. And of course, there were laws in that time that prohibited interracial marriage or relations. So in 1933, which is really when we were recovering from the Great Depression, the federal government put together the Homeowners Loan Corporation, which was supposed to invest on the community and building homes for Americans. And what they did was they literally drew red lines around those communities that were predominantly African American, basically saying we will not give loans in this area, and categorizing them as hazardous areas. And what we know now, by doing that, they set up environments where the actual environment started to affect the health of those that lived there. So, there were many structural ways that we have contributed in the United States to the inequities that exist today. Then in the 1960s, you had the passage of the Civil Rights Act. So now hospitals are being told, if you continue this segregation, you will not get money. You will not get Medicaid, Medicare funds. And in fact, that's what really changed a lot of the behavior during that time. 1985 was the first time, this is Margaret Hexler's report, which she was the Secretary for Health and Human Services, and she put together a task force to look at whether or not there were differences, true disparities in care, and who were being affected. It was the first time the federal government had really put some money into this. So they found that there were 6 causes of death that accounted for 80% of mortality among Blacks and other minority groups. And those are it, right? What you would consider, what you would already know, which is cancer and cardiovascular disease, diabetes, injuries, infant mortality. These were the things that basically started to get some light in terms of disparities. So just the differences of health outcomes. So then in 1997, you had like a revision of what was the classification of race for reporting purposes. And then in 1924, we have another revision. Now, instead of having the questions of Hispanic, non-Hispanic, and then race, you have Hispanic actually as part of the questions that are asked when we're trying to get information about race, ethnicity. And they've added also the Middle Eastern and North African box, because they were getting a lot of others, unknowns, multiracial. They weren't really understanding the population that they were surveying. So again, as we know, it's a classification system, so they've kind of helped with that. And then in 2003, you have Collins and Ventnor, who were the leads for the Human Genome Project, that then come out and clearly state that there is a lack of scientific and genetic basis of race. So really putting the science behind this and saying this is just a human classification system and nothing more. Then the IOM, which is now the National Academy of Medicine, in 2003 brought together many scientists, and it was actually an interdisciplinary group that looked at over 100 studies to write this report, where they basically stated that race and ethnic minorities received lower quality of health care, poor health outcomes, and higher morbidity and mortality from the leading causes of death than their white counterpart, and this is the point, regardless of the socioeconomic status, which was huge. Now it wasn't just there's a disparity. There's a disparity even when you have access to care, even when you have the insurance to go. You have poorer health outcomes than the white counterparts. And they also came out with the fact that we needed to understand our own implicit biases and how that was playing, and our own stereotyping, how that was impacting the health outcomes of our patients. And I will say, well, it's a difficult conversation to have. We all have implicit biases, right? And so the way that one deals with this, I think, is by having those personal conversations with yourself and making sure that whatever those biases are, that you are aware of them. It's the only way to really, hopefully, help with this aspect of impact in the decisions in management. So what did they recommend? They recommended awareness of the fact that there are even disparities. So really getting this out, coupled with education, not only education that it exists, but also the culture of humility and competency, and then also addressing the systems of care, because that's a large piece of what influences health disparities. So, basically looking at the data collection, even having data collection at that point, basically looking at the quality improvement metrics, seeing whether or not that was a framework by which we can look at disparities. And then, of course, community outreach, improving workforce diversity within medicine, and also a focus on interpretation as a way of hopefully helping with our differences in care. And then, of course, patient education, and then, of course, really encouraging research in this area, which they did for a long time. And then, fast forward, a couple decades later, they come out with Unequal Treatment Revisited. So how well did we do during this time? They gave us kind of like a little blueprint of what we could do to make things better. But the actual report basically stated that we didn't do very much fundamentally to change the nation's healthcare system enough to really improve upon health disparities. They actually reviewed 221 papers, emergency medicine papers, and what they found there was that, great, we were writing about health disparities, but we were writing about the identification of health disparities and not so much about what our interventions would be. And so something that we should think of as a specialty going forward. So the revisited paper basically also gave us these major observations or recommendations. I would say that it's fairly the same. You've got to get good data. You really do need to partner with the communities. You need a diversified work group. Not much difference, except that now they're asking for accountability. They really want the fact that there should be improvement on the payer mix, so not this discrepancy between Medicaid and Medicare, which many states, although I think I know that you guys don't have such a discrepancy, but many states face. And then the accountability of the insurers, making them accountable so that if this doesn't exist, they would end up holding financial responsibility for the inability of getting to the outcomes that we would all share in saying were equitable outcomes. So, I show you this. Many of you have already seen this, picture of showing kind of where we are now, where there's these huge disparities that are created among groups, and what we need, where we need to go. It's not just giving equal things to people, especially if we're not meeting them where they are. It really is about equity and getting people kind of raised up, as this shows, so that we all can have, the chance of good health outcomes. Now, of course, I love this one because it shows the justice piece. The fact that if we didn't need this at all because these barriers didn't exist, wouldn't that be what we really want? And I think that this really reminds me of what we really want to strive for in healthcare as a whole. I do want to point this out because this is, I think, really important. We use health disparity and health inequities interchangeably, but they mean two different things. The Heckler report just talked about health disparities, right? The difference in the health status between people that are related to social or demographic factors, right? That's what they talked about, right? But when you saw the first unequal treatment, they were talking about true health inequities. And as I highlight there, they arise when certain populations are made vulnerable to illness through inequitable distribution of protection and support. This is clearly what happened during COVID. And I think what COVID did for all of us is it shined a light on what we cannot no longer look away from. Each of us, regardless of the specialty, I believe, have a certain moral obligation to be thinking about this and thinking about your own practice and how you make that practice better, because we can all improve in our practices. I put this up because the things that contribute to the healthcare disparities and health outcomes can sometimes overlap, but sometimes be different. And I again want to emphasize that the one conversation piece that we need to start having a little bit more of is about bias and stereotyping. There's nothing wrong with it except that people get uncomfortable with the conversations. But if we're going to make true changes and really try to forge ahead into a different world of medicine, I think those conversations have to be had. And how it plays into the equation that leads us to either the disparate care, which is just differences, or true and equitable care. We know that medical care in and of itself accounts for about 20% of what health outcomes typically are, right? So it gets us into the social determinants of health. And yeah, this is the definition of it. And a lot of you have seen this, and probably this picture is more, resonates with you more. I think that this is, again, a great way of describing COVID. All of these areas, these 6 discrete buckets of economic instability that happened during COVID, the housing and transportation issues that occurred, certainly the education issues that occurred or lack of, the food deserts that happened. These are the areas, these are the determinants that are definitely linked to how health outcomes arise at the tail end. But having said this, it gives you a sense of this continuity, a continuum of sorts, as opposed to this dynamic process of what this truly is. This is a different frame I think, a frame of looking at health equity, which is you not only have the social determinants, but you have the political determinants, you have environmental determinants, economic determinants, how it interplays with each other, right? Because it's interconnected, and there's a lot of intersection that occurs. But more importantly, it's dynamic and it's not a continuum. It's constantly changing for people. And so I think when we start thinking about how complex this is, right, for us, I would say don't stay in that area of complexity, but start to think about within your own practice how you can make a difference. So in 2021, during the course of COVID, post George Floyd's murder, CDC comes out with a statement that I think we can all say, sure, it definitely is a serious threat to our public health. But with this, I want to say that it's important for us to understand that the complexity of this is about the history of it, right? And so while we understand the history, we can make these changes going forward, because this is not one person, this is not one institution or one structural piece or one health policy piece. This is multi-layered over a long, long time. And so we have to peel back the onion little by little as we try to change things. There was a lot of talk during COVID about the redesign of healthcare delivery, right? In some ways, we did redesign healthcare delivery with the telemedicine piece. But one thing that I think most medical schools and most health systems started to really accept was we kind of have to be uncomfortable a little bit and have these real conversations about how we can tear apart that onion and get to the bottom of different things and try to change the structural pieces that we can, try to influence the more individual pieces that we can, which is really this, right? We'll try to change we have to identify the structural pieces, we have to identify the institutional pieces, but the individual pieces, that's us. That's us learning about ourselves and how we practice medicine and how we see the world through our own eyes, from our own experiences. So I like to show this because this is Murphy and Braveman are economists that for many, many years was looking at this it went by itself. Let me go backwards. They were looking at life expectancies between whites and blacks. And as you can see, every 10 years you have an increase in life expectancy, but the gap remained. Well, then you had this modeling that was done actually, and it shows on the left-hand side how by 2035, that gap was about to close, right? With all the work that we've been doing over the course of decades. But then COVID happened, and as you can see, the gap is spread. Now, we really don't know where we will land in terms of our life expectancies by race, ethnicity, and something that I think people are looking at right now and trying to make heads or tail of what COVID's long-lasting impacts are going to look like. This is from I'm sorry, a blurriness, but it's a lecture that Dr. David Williams gave. He's a sociologist from Harvard, and he basically, showed what I think really represents unequal treatment, the first one, which is that blacks with college degrees have a lower life expectancies than whites with only a high school degree. Again, showing that whole idea of socioeconomic status really doesn't matter. You still have this discrepancy, and why? That's the question that we have to answer. So now I'm going to switch over to emergency medicine a little bit more. I talked to you about the 221 studies that they looked at in the revisited, in the sequel of unequal treatment. I will say that while a lot of it was focused on identifying the issues and not so much on the intervention, I think we have a real opportunity in emergency medicine to start looking at that. So I don't know if some of you read this, or for my older esteemed colleagues. So in 1993, Todd et al. Did this study looking at long bone fractures. They did it from UCLA. It was a retrospective study, and they basically found that 55% of Hispanic patients who came in with long bone fractures did not receive any type of pain medication, as compared to the 26% of white patients, right? It was a pretty big deal. Then in 1997, he does it again. He does a similar study, but now he's doing it at Emory, showing again 43% of blacks not receiving pain medications for long bone fractures, and as compared to the 26% of white patients. But what I found interesting, kind of to speak towards the sequel of unequal treatment, this is a study that came out in 2020. So now you go from 1993 to 2020, and what you have are the same kind of studies basically saying, no difference in pain scales. You still had white patients were more likely to get pain medication for a long bone fracture. Again, we're not talking about interventions, right? We're just talking about the identification. And it's over 20 years of saying the same thing. So my plead to you guys is, let's start looking for interventions. Let's start understanding what we have in front of us in our practice, but then let's look at how we can intervene, and then let's share this with our colleagues, because it is an important aspect of our specialty. And this isn't just another paper showing that people of color versus white individuals that come from the same zip code were being taken, those of color were being taken mostly to safety net hospitals as compared to the white patients from the same zip code. Just again, disparate care. So how do we do this? How do we have an actionable plan? Well, we know the 3 buckets that are important are going to be the diversifying the workforce, the education piece, of course, on a lot of different levels, and then, of course, can we use quality improvement, that infrastructure, to really start looking? It's low-hanging fruit. We don't have to boil the ocean here, right? We want to just start with the things that we can manage, and then you build from that. So this is just to show, with respect to physician workforce, you could see the U.S. Census from 2024, and on the left side, the stats for all physicians from the AAMC. So you can see that while, let's see, Hispanics make up 19%, almost 20% of the population, but they only make up 6% of physicians, all practicing physicians, not only emergency medicine, but all practicing physicians. The same is true for Blacks, the same is true for Native Americans. So we're nowhere near where we should be in diversifying our workforce. If you look at emergency medicine physicians, it doesn't even come close to what all physicians' stats look like. It's a lot less of Hispanics, African Americans, certainly Native Americans. And so I think this just speaks towards the fact that, again, diversifying our work group, we already know is going to be a good thing. I feel that's a low-hanging fruit right there that we could work on. And when I talk about, by the way, the diversification, it's not just race, ethnicity, it's lived experience, right? My lived experience has informed me quite differently than probably some of you in your practice. So I would say, looking at those lived experiences that are different, recognizing that that could add to your team is a really, I think, a big deal. And this is just showing nursing workforce, which is no different. So education. The one thing I do know that some of the things that were positive that came out of COVID are medical schools really started evaluating their curriculum and changing it, and really including this aspect and concentrating on health equity, and that we're seeing across the United States. And in emergency medicine, I would say we are doing the same, and I think we need to continue that task of looking how we teach health equity to our residents, how we actually look at health equity from the emergency medicine lens. And then, of course, there are many places that have fellowships that are focused on health equity and social justice now in emergency medicine. So I do think we're getting there, slowly but surely. But this is just to say more work has to be done to push this agenda, I think. Now, when we're talking about quality and the infrastructure there, I think this is an easy win. Whether you use quality improvement or you use safety, right? You can take data, your safety data, if you have like a safety net reporting mechanism, and look at that with the lens of equity. Are we seeing a lot more safety issues because of interpretation issues, right? Are we seeing safety issues around disability? So you can really get a sense of taking something like that and making it into a question of health equity. The same with the structure of what I would say is the quality improvement structure. Now, IHI came out with this model. You guys probably know it, right? It's the PDSA cycle. You ask a question about something that you want to improve, and then you plan on what you're going to do, and then you do it, then you analyze it, Did it work? Did it not? Do we need to tweak it? Then we go back and we do it all over again. And I think this is a structure that looks at not only the structural metrics, but also process metrics. And for emergency medicine, a lot of our metrics are about process and how that actually influences the outcome of our patients and their management. But what if we just added this equity measure, right? Taking a measure that we're already looking at, we're already reporting, and then stratifying. Not just race, ethnicity. You could do it by language, disability. You could do age. You could look at the geriatric population, right? Are their outcomes worse than the rest of the population that you're seeing? So this is to say there are many demographics that you can look at, many pockets of vulnerable patients, right? You can look at infants. So I do think that there's some real low-hanging fruit here that we can take advantage of when thinking about emergency medicine and how we look at health equity. What can we do from that perspective? I want to underscore that you got to get good data, though, right? And in a lot of our places, unfortunately, our data may not be so great on the demographics that we want to look at. So that is key. Then you want to identify what the differences are. You may not identify inequities, because I wouldn't say go for that first. I would just look for differences within the subpopulations before I would even say something like something's inequitable, because it's quite different meaning again. And so once you find that and you stratify by all these different things that you want to look at, and by the way, the literature is full of this stuff, right? Even though they just looked at 221 papers at the National Academy, there were many more publications around where we have identified things that are wrong. And so there are metrics out there that we can look at. It makes it quite easy for us. And then, of course, implementing evidence-based interventions, or maybe creating an intervention and then validating it yourself. I would say that it's super important to empower your emergency medicine quality leads to start looking at this in a way that's meaningful and generating, hypothesis. I think once you find the difference, you have to look at all the little things those modifiers that can actually make a difference. That if you intervene in that specific targeted modifier, you can actually change something. And then, of course, you have to monitor. It's important. So I'm going to go through very quickly this case. Really simple, just to give you an illustration. In my last life, I was looking at left without being seen. Now, if you look in the literature, there's a ton on left without being seen. Basically, who are the people that commonly leave before they're seen by a physician, and what are the modifying variables with that. So looking at the literature was very helpful for me. Then I recognized that my capture rate, meaning the data, sucked. So I had to, before doing anything with left without being seen, I had to go back and do multi-educational pieces with the registrars, with the providers, with the nurses, so that everyone got on board with this is an important aspect of getting this data for us to be able to analyze it. Then once I did that, I went back and identified the pockets of differences with left without being seen, much like what was in the literature. And then we put into effect the intervention, and we tracked it. So here is the capture rate. And if you look, 2021, other and unknown, it's almost, it's not too far away, and especially if you combine them, it's even more than any race or ethnic group by itself, which only tells me that the data is no good in order of looking at a difference. But then we started doing all the educational pieces, and we added to it the first hour, which is auditing, making sure that if every day, twice a day, the managers would do an audit of how many patients are in the emergency department who have other and unknown. And has the registrar gone back to clarify that? Once they started doing that, you could see the trend became better, and we started to get a lot less others and unknown. And then, of course, we started to do kind of hourly audits at the tail end, which again, affected the amount of others and unknown. People started going back and asking patients, hey, this was what was in your chart. We just want to make sure you understand why it's important for us to understand what you identify as. Then I was able to look at left without being seen, right? And what I know is, all throughout the literature, if you triage somebody and you put them back out in the waiting area, the likelihood of them leaving is a lot higher. But if you triage someone and you get them into a room, the likelihood of them staying and being treated is a lot better. And that's the same case here. We looked at people who were admitted, so door to room, admitted, door to room, discharge, right? And then door to room, left without being seen. And as you can see, just even visually, they waited longer on average. This is an average. They waited longer in the waiting area. And if you really looked at it closely, it was young black men who were put out in the waiting area much more frequently, and so they left much more frequently. So what did we do? I think all of you know the answer to this. It's a provider and triage. But it's the first step of provider and triage. And once we started doing this, the blue line shows all of time. When we added a provider and triage Monday through Friday, you see the decrease. Then when we added the weekends, it actually affected it more. And you can see it on the pink line. The pink line just shows you left without being seen when you have a provider and triage, and the difference then all of time. But then the next question is, of those that are patients that were brought in and left before treatment complete, who are they? Were we doing the right intervention? And in fact, I left before I got that answer, but I suspect the left with, prior to treatment completed is a subgroup that we need to look at just as well. So it's not enough to put someone in the provider and triage. You really want to make it so that it's substantial, the intervention, not just a checkbox, if that makes sense. So I think we can agree. There can be no progress in healthcare without equity. That's just part of quality. Can't have one without the other. And I'll leave you with probably one of my favorite sayings, which is from James Baldwin. Not everything that is faced can be changed, but nothing can be changed until it is faced. So with that, I leave you. I thank you for your time. I thank you, and I really hope that this is just the start of a conversation for all of you, so that you can start asking questions and looking at the data. And if the data isn't good, then start creating frameworks that help you get better data, so that you can really meaningfully start looking at some of these metrics and seeing whether or not there are subgroups that actually have a difference in care. And I think that's low-hanging fruit right there that we can start with and then build upon. So thank you. Thank you. So I can answer any questions, if you have any questions.
Do you have any examples of places where you've worked where you have made like these interventions? I know you talked about PIT providers, but any other interventions that notably improved equity in an emergency department?
Well, pain evaluation was the next thing that we started doing. Looking at, I mean, it's all over the literature, right? 25 plus years of we don't do a great job with long bone fractures. I would make the argument that we probably don't do a great job in pain as a whole. What I could tell anecdotally, but I could not show you with data, was that the subgroup were those that had substance use disorder, who came in pain, who were not treated either timely or with the right medications when you reviewed some of the charts. But because our data collection was not so great, we decided we would just look at, with this intervention, using nursing as our partner, being able to say, this is of someone who has X amount of pain, right? The pain scale is over 5. And then going and making sure that once that pain scale was done and the time by which the physician saw the patient, wrote the order, with prompting by nursing, and that helped significantly. Now, not enough for me to sit here and say I published it, because I haven't published it, but it was a beginning of looking at that process of becomes a lot more difficult when you're looking at subgroups like, patients with substance abuse disorder. But think about it. I could say the same for looking at the other vulnerable group were those that were deaf-mute. They waited about 2 or 3 hours longer to get pain medication, right? Which, I mean, come on, right? I mean, in some ways, you think about it, you go, you get the machine that then does the translation, unless you have someone in-house and you're waiting for that person, blah, blah, blah. But we just have to do things better. The process there needs to change, right? So I would say, again, it's like looking at these different pieces that are already in the literature and saying, does it exist in my data? You had a question?
Yeah, I was just wondering how you think hospitals should react to changes in the Affordable Care Act and Medicaid and Medicare reimbursements.
Say that again.
How do you think hospitals should react to changes in the Affordable Care Act and Medicare and Medicaid?
That's a loaded question. Thank you.
Sorry.
No. Listen, I know what I think as a human being, but I also understand there's a business of medicine that we have to think about, right? Different from my time in residency, and I will gladly admit that. It was a different time. But now we are looking at the business of medicine, right? But I will say this. If you want to talk about finances, health disparities in this country cost us over $400 million, like really a year. Close, going over $500 million a year. That's a lot of money. Educational disparities in this country cost us close to $1 trillion a year. So it is a bit of the finance. If you want to have an argument when you're sitting with your bosses or your higher-ups, looking at the finances is one way of doing it and showing that, in fact, if we were to do some changes, there are some financial gains that could be had. And I've done that in the places that I've worked at, where it counted, right? And for example, left without being seen, right? Value-based metric. Look at that and say, what do I need to make that better so we're not penalized on the back end, right? That's a conversation that can be had with I think, senior leadership, understanding that you still got to pay the bills, right? And if you have a system by which your state really recognizes the importance, then you're golden. In New York, H+H, which is the Health and Hospital, which is the largest public hospital system in New York City, right? I mean, they get bailed out quite a bit from the state. As time goes on, they're recognizing themselves. They can't rely on that because it's not a good business model. So, again, I think when you want to have a conversation about this, I'll say this. You all have a lot of power as a physician to advocate and to advocate for what you think is needed within healthcare. So you all have voices. And we have organizations that try to utilize those voices to make some changes. The health policy piece is really important. And if that's of interest to you, then that's something where certainly that will impact healthcare as we go forward. We all know that. So I don't think it answered your question, but I would say that's what I got for you.
So thank you very much for being here and giving this presentation. We kind of talked earlier, but my question for you would be, given the current political climate, and how do you navigate the polarization that some of these conversations are causing in today's world?
Yeah, I think that's why I kind of stress some of these conversations are so difficult. I do think one way of level setting is what we really want as the best healthcare for everyone. And that level sets everything. I don't think anybody, from wherever you're coming from, is going to argue that they don't want good healthcare for everyone. That's what we want, right, as physicians. And so there's going to be polarization. I think we have to find the common grounds, and I think we have to find it so that we can move this agenda. Health equity is important, whether you talk about it from a financial aspect, from a moral aspect, from a political or policy, aspect. It is what will change the United States going forward. Otherwise, we're doing this wrong, and at some day we're going to pay the piper, right? It's going to implode on us, and we don't want that. So I think one thing that all the specialty boards on the American Board of Medical Specialties understand, because I'm on their health policy committee, is that the health policy in this country is critical, and we have to be a part of that conversation. We just do, as emergency medicine physicians. The more that we are, the more that we can do advocacy for the things that are important to us. And I'll go back to the very beginning, because, the mantra is the mantra. And emergency medicine really was born out of the social justice thoughts of individuals that really cared about the patients that they were taking care of. No different than you guys. No different than you guys. And you had Art Kellerman in front of Congress opening up a bag of all of these, these arm clips where patients were just dropped off, and it was wrong. It was dumping, and these patients were dying. So, there are giants out there that have taught us the way. So it's nothing new. It's not reinventing anything. It's just making sure that if this is something you care about, that you're actively doing something about it. Whether it's within your own practice, it's something small. It's still something, and everything counts. So, from my perspective.
So I know you're not speaking on behalf of ABM necessarily, but the code of professionalism kind of hit the popular press this year when people wrote that editorial in the Wall Street Journal about the implicit bias pledge or whatever. I guess my question is, how is that not just checking the box instead of like doing something like bigger, or making an impact rather than just checking a box when we recertify?
So, like anything you do, and again, this is Yvette Calderon, this is not ABM, okay? It's not Thomas Jefferson, it's nothing. It's me as a human being and as a citizen. Sometimes all you can do is remind somebody that this is important, right? When you don't see like a real unprofessional act on the other side, which I would think that a lot of the leaders here have seen, it's scary. Not everyone has the same moral compass. Not everyone has that North Star that potentially you and I share. So sometimes all you can do as an organization is remind people this is important. And where you take it, that's on you, right? And I do think we have, personally, as a woman of color in a business that's male-dominated, I do think we need to have those conversations, right? We need to remind each other about what's important. And it's uncomfortable, going back to how uncomfortable it can be. So I respect if someone sits in front of me and says, I don't want to do that, I respect that, then don't. We all have choices. Whatever the repercussions of that later on, that's on a choice that you made as a physician, as a person, thinking about whether or not something's important or not, right? And unfortunately, a lot of things get conflated with DEI, God, right? So they're triggering words, unfortunately. But diversity is not a bad word in and of itself. I think all of us would agree we like to have an inclusive environment where we can come in and all hang out and feel like we're part of a larger group, right? And equity, well, this is what I've been just talking about for an hour, I think is critical in healthcare. And I think that for all of us that really came into emergency medicine with that fire inside of us saying we want to take care of these patients that are vulnerable at the most vulnerable time of their life when they come through an emergency department, speaks to where we are as physicians and as human beings in society. So I actually think, these words are not bad. How they are conflated and what you make of it is something different. But equity that's, I think, so I will end with this. I like going to, I was just talking to Adam about this, I like going to the medical school graduations. I do. They always invite the chairs, and I love going. Every year I go. Why? Because I get up, and I get to say the oath again. And I get to remind myself why I'm doing this job. And it is powerful, right? When you have to get up and say the oath, and you're in an auditorium, and you're looking at these kids that are just graduating, that believe every word that they're saying, and if you are their role model, right? It's a powerful thing. So for me, it's about knowing what my North Star is, knowing what my true compass is. And I think because I was and have been in emergency medicine all my life, my adult life, it has helped me with that. And my mentors have helped me with that. Those that have taught me have helped me with that. So no different than what you're trying to do here with your residents. So hopefully that helps. Great questions, though. Well, again, thank you.